I get the pleasure of introducing Dr. Rick Page, who is the Sampson Visiting Professor this year, and Werner and Joan, who are not in the room at the moment. I want to extend our heartfelt thanks to them for making this event possible every year, giving us a few days with esteemed colleagues who get to come and share their wisdom and their experiences through the course of talking to folks, a couple of grand rounds, meals, all that sort of thing. And as I understand, it was a delightful meal with the fellows the other night. For those of you who don't know Dr. Page, many of us do know him because he used to be here. His course started at Duke University, boo Blue Devils and their basketball team, but he was an undergraduate and medical student at Duke, was a Sarnoff Fellow, which is a research fellowship for those of y'all who aren't familiar with it, where he spent a year at Columbia, did his residency, internship and residency at Massachusetts General Hospital, and then went back and did his cardiology training at Duke, and then went from there to UT Southwestern, which began a migration of increasing liberality in his geographic locations. He was here as the head of the Division of Cardiology, and then went to Madison, Wisconsin as the chairman of medicine, and is now currently the dean of the School of Medicine at the University of Vermont in Burlington, which is, I will say, exactly according to his career plan as I recall it. I got to participate in the hiring of Rick. At the time that he was interviewing, we as fellows, two of us fellows, got to interview him. And in keeping with what we would do to him in the future, we made him late to meet Bremner, me and Nana. Go us. We continued that now, well, always. And I will throw in Rick, one of the things that was a defining feature when we were all fellows is his adherence to professionalism. And professionalism is a variety of things, like don't drop F-bombs, some of the obvious stuff. But also for Rick as an East Coaster, it's also that ties are the right thing to wear all the time, and that scrubs in a fleece vest are a horrible idea. Dr. Perlman, wildly renowned for coming into a faculty meeting and said scrubs in a fleece vest, was while this conversation was going on, said, if I don't have the vest, where am I supposed to put my ID? And so it caused enough terror for the fellows that fellows going to ACC or AHA with even the slightest possibility that Rick would be on the plane were in full suits. Not jacket and slacks, but full-on suits, terrified that they might run into Rick. But he had all these other endearing, funky qualities, like, as I recall, Captain Crunch for breakfast and some stuff like that. But most endearing to me is that he hired me. And the world really is all about me. Okay, it's not. But I was extraordinarily fortunate to have amazing mentors here, Catherine, Alan, a variety when I was a fellow. When it came down to it, Rick actually hired me and invested in me. And every day that I come here, grateful to be able to work at the University of Washington, grateful to live in Seattle. He has a huge part in that, and I am intensely grateful for the mentorship and the willingness to take a flyer on a reasonable lunatic. And in honor of that, we have a gift as we introduce him. I know you actually should be worried, but this is credit to Rob. This was his fabulous idea. That's right. So, the good Dr. Page will come up and tell us about atrial fibrillation, which is one of his academic interests. I am sure he's not going to swap the jacket for the vest, but later he can do so. The UW Heart Institute fleece vest. Thank you, Dr. Page.
Thank you, Dr. Stout. And thanks for being kind, Karen.
Yeah.
My goodness. Now,
I didn't have enough
fairness, as over the last number of years, I've said many times, I've given up on ties. Seattle beat that out of me. And but nevertheless, fleeces on rounds still don't fly, Karen. So, in talking with Rob about this talk, as opposed to medicine grand rounds, I want to share with you a bit of my own personal journey in an area of at the time I got into it, great interest, and that is antiarrhythmic therapy for AFib and flutter. It's interesting that even though it remains a great interest of mine, the latest update on the AFib, A-flutter guidelines don't say anything about antiarrhythmic therapy, because not that much is happening in new investigation ablation, and it's all, the shiny object is ablation, which remains outstanding. But at the same time, we still use drugs and we still need them. So I'd like to share with you my own experience and my own perspective on what we're doing with antiarrhythmic therapy. These are my disclosures. I have no conflict of interest. I will be discussing Amiodarone and Ranolazine, which are not approved for the management of AFib. And this morning we're going to talk a little bit about rate versus rhythm control and mechanisms of antiarrhythmic therapy, and talk about the current guidelines for what we have and new drug opportunities, which I remain optimistic for, but clearly have some issues. Well, just in terms of my own personal experience, as a surgery clerk, I was assigned to an operation called Wolff-Parkinson-White surgery, performed by Will Seeley. I went to EP lab and John Gallagher, and those of you in EP, these are the giants of EP in the early 80s and late 70s, and had the opportunity to watch WPW ablation with a scalpel and an open chest. And thank God I didn't want to be the surgeon. Because 10 years later, they were out of it, and these rudimentary catheters were improved, and we were using radiofrequency energy to ablate lesions, atrioventricular pathways, that as opposed to being in the hospital for a week post-op with a median sternotomy, patients went home the next day cured. Now, I had great mentorship, and I got to tell you, it's amazing being here, and any little piece I've had in anybody's career here, it warms my heart to see people all grown up, including someday Dr. Stout. So I had great mentorship, and I was awarded the Sarnoff Fellowship, and I wanted to be a clinical EP, and they said, great, wait, and go to a basic lab. So this is me, 1982, a little bit more hair, a little bit darker, even bigger glasses, but I'm proudly sitting in front of my rig, and there's a Faraday cage for any of you who recognize, and I don't know where so the Faraday cage is electrically isolating, and this was for one set of experiments, but I went into the lab, in the basic science lab in a pharmacology department, and little did I know that that would actually give me a little credibility in my current life, having 4 basic science departments, having lived in a basic science lab, working with flecainide and working with models for atrial arrhythmias, and it was a fantastic year, and it was New York City in the early 80s, and I had that hair, and it was a great time. Let's talk a little bit about rhythm control for AFib, and again, I'm concentrating on antiarrhythmic therapy primarily. What's the goal? Well, you want to improve symptoms. It's all about symptoms in atrial fibrillation management. Maybe reducing the AFib is a good thing, but certainly bottom line is, does a patient feel better? You want to reduce the AFib burden. This is more and more a measurement, and I'll talk about kind of endpoints for antiarrhythmic therapy, and this is one endpoint now, the burden being just how much you're in AFib, whether you feel it or not. You need to consider whether there's a phenomenon called AFib begets AFib, and we'll talk a little bit more about that. The fact that the more you're in AFib, the more you're going to get AFib, because actual changes, remodeling of the atrium itself. Now, you don't maintain sinus rhythm to reduce the risk of stroke. Nobody's ever proven that that is an effective mechanism to reduce the risk of stroke. The risk of stroke is reduced by antithrombotic therapy as appropriately delivered per the guidelines. And it's not about reduction of mortality in general, although some of the later studies may argue that, but I'm not fully convinced. So, for me, in terms of clinical care, how symptomatic is the patient? If they don't care much about their AFib, usually I don't either. And also, what is the chance that you can maintain sinus rhythm in the patient? How hard are you going to work for a marginal benefit? Now, yesterday I got to meet with the fellows, and they showed me some wonderful cases, and I learned a little bit about lymphoma, but that was aside. I don't know anything about lymphoma. But we actually talked about action potentials, and I was really impressed at the fact that your fellows still are learning about this stuff. But just to remind you, the cardiac action potential has a number of phases. You have your fast inward current, which is sodium. You have your outward, and you're maintaining your plateau with inward currents, and your potassium currents help to repolarize. And just to remind you, the action potential duration relates to the QT, and the QT relates to Torsades de Pointe. So anyway, we were taking Purkinje fibers from dogs and studying these, and looking at the effect on the action potential and the rate of rise of upstroke of the action potential as a measurement of antiarrhythmic therapy. So this is my desk in Brian Hoffman's lab. I'm a little bit neater now, but not a lot. And this is actually the microelectrode puller. In those days, you had to pull your own microelectrodes. That was something I learned to do. And for the younger people in the audience, this is a roll of film, and this is a telephone. So what about the cardiac action potential? How do we modify this? Well, as you prolong the action potential duration, you prolong the QT, and that is, and the bottom line is, as you increase inward current or decrease outward current, your action potential will prolong, and that will increase the QT interval. Why does that matter? And I'm going to show you an oversimplified concept, but it gets at least across part of the idea of what we're doing here. If AFib is indeed a bunch of reentrant wavelets that are maintained by having enough volume of tissue to have all these reentrant wavelets, as you see here, if you modify the refractory period of the tissue and increase the wavelength, so in this tissue perhaps with 9 wavelets, now if you have a great effect and make the wavelength longer, you can only fit 2, and hypothetically in this amount of tissue, and if your tissue is modified by how big the atrium is or how you've sliced it up, either surgically or with a catheter, perhaps by prolonging the action potential duration, you can't sustain the mechanism of atrial fibrillation and you wouldn't have as much AFib. Well, in both goats and dogs, it's been demonstrated that AFib begets AFib. And what that means, basically, if you take a goat or a dog and you pace them whenever they go out of AFib, or whenever they're in sinus rhythm, and just rapidly pace them into AFib, what do you know? After 24 hours, your duration lasts from, instead of 5 seconds to 20 seconds. And if you have this special pacemaker in for 2 weeks, the AFib persists. So AFib begets AFib, and that has to do with atrial remodeling. And remodeling of the atrium is the opposite of what you do for your kitchen. You don't want to remodel the atrium in this way. It's kind of crazy. We call reverse remodeling in atria to make them better. But just conceptually, the remodeled atrium has a shorter action potential duration, which will allow a shorter wavelength, not a longer one, which is believed to play at least a role in persistence of atrial fibrillation. So just to remind you, now we're going the opposite direction. You've got shorter wavelength and greater possibility of maintaining atrial fibrillation. Now, this is taken back from the days when I was in the EP lab. And this demonstrates what you want. The first 3 leads are surface leads, and then, or the first 4 surface leads, the right atrium, his, and coronary sinus. And any of us can see that in the leads that record some atrial activity, it's chaotic, and then it breaks, and even on the surface you can see AFib breaks to sinus. You've got a little HISP on the recording for the EPs. I know it's not that big. But this is what you want from your antiarrhythmic therapy. This is what you don't want. This is not VT. This is wide complex tachycardia. Flecainide, we talked about flecainide overdose. Even at therapeutic doses, you can end up with a slow flutter that conducts one-to-one with aberration due to the antiarrhythmic drug and use-dependent sodium channel blockade, and you get this wide complex tachycardia, which parenthetically worries the person looking at it very often more than it worries the patient. It's not as bad as it looks, but it's poor form to give that to a patient. This is what you really don't want. And this is from a paper that Dan Roden and I put together actually while I was here. And this is from an experimental drug that they used in Vanderbilt, where they took the patient at baseline in AFib. They gave him this drug, which never went beyond these experiments because, my goodness, look at that QT. But the good news is it broke the AFib. The bad news is the drug that was there for the atrial arrhythmia was proarrhythmic for the ventricle, and everybody should recognize this as torsade de pointe that's related to prolonged QT. So if you're going to treat atrial fibrillation, what are the mechanisms? How do we get there? And back to the action potential and the various channels, and we'll talk more about these in a bit, the various channels that you can poison with your antiarrhythmic drugs. The sodium channel for the class 1 drugs is a target for flecainide, propafenone, and quinidine, which we don't use anymore, procainamide, disopyramide, as well as with different effects of the class 1B drugs. And then the QT prolonging drugs are primarily going to the potassium channels. But look at all these other channels. Might they potentially have a role? And we'll talk more about those opportunities in a few minutes. So to remind you of the Vaughan-Williams classification for antiarrhythmic drugs, class 1 are the sodium channel blockers. Class 1A, quinidine, procainamide, disopyramide. 1B, not useful generally in AFib. Class 1C, flecainide, propafenone. The class 2 drugs are the beta blockers. They play a role in AFib in terms of rate controlling, and for that patient with flecainide, you want to make sure whenever you're starting a class 1C drug, you're providing nodal blockade, so hopefully if they do go into flutter, they don't go one-to-one. Class 3 drugs, potassium channel blockers, Sotalol, dofetilide, Amiodarone, and Dronedarone, which we'll talk more about. And finally, class 4 drugs, calcium channel blockers. These are the drugs that are actually used clinically. Of the class 1 drugs, flecainide and propafenone have a role. Sotalol, dofetilide, amiodarone, and dronedarone. As I mentioned at the outset, amiodarone is not approved for atrial fibrillation. A lot of people are surprised by that. It's in all the guidelines. It is the most potent antiarrhythmic drug we have for AFib. But it is not approved. It will never be approved. Why bother? And likewise, it has toxicities, which we'll talk about in a little bit, that are significant. The Holy Grail is a drug that doesn't have all those toxicities and is as effective as amiodarone. So in terms of class 1C agents, as I mentioned, flecainide, very well tolerated. It's a BID drug. It is effective for AFib and PSVT. It's not as effective for flutter. The CAST study in ventricular arrhythmias, all patients in CAST had a prior infarct, and they died more, even though their PVCs were suppressed by flecainide. So they felt better, they died more. That's why you don't give 1C drugs to patients with structural heart disease and certainly with ischemic heart disease. That being said, in a normal heart, I will prescribe flecainide before I'll prescribe ablation in most patients. And in some patients, you can wipe out the AFib. It can do an amazing job in some patients, and dosed carefully and appropriately in the right patients, and we'll talk more about who those are. It can be, and for me, is very often first-line therapy. Propafenone is also well tolerated. It causes a few more side effects, and generally I find less success with propafenone. They're both FDA approved for AFib. In this class 3 agent, Sotalol and dofetilide both affect the potassium channel, IKR. Sotalol has beta blockade effect as well, and it can be limited by bradycardia. Dofetilide doesn't have that. It has more complicated dosing. Both of those should be initiated from my perspective as an inpatient and are labeled as such. Amiodarone, on the other hand, is the most effective, as I mentioned, but has a non-cardiac toxicity. For those who were practicing a couple decades ago, this face is not unfamiliar. Before we had ICDs, we had amiodarone. And we would give amiodarone to the point where you would get this slate gray skin discoloration at higher doses. That didn't cause people a lot of problem. We just tried to keep them out of the sun. But most people didn't care to have that side effect. On the other hand, amiodarone has significant liver, thyroid, eye, and increasingly I've seen CNS complications. The pulmonary complications can be life-threatening. The fact is, in AFib dosing, as opposed to 400 a day or even more, for steady-state dosing in ventricular arrhythmias, back when we didn't have anything else to give patients, at 200 milligrams a day or less, you don't see those complications anywhere near as frequently. So, what case can be made for antiarrhythmic drugs working at all? Couple major studies, and again, this is not the hotbed of new investigation, so we need to go back a few years, is the CTAF study. And CTAF actually compared amiodarone to two of the most commonly used AFib drugs, propafenone, the 1C drug, and Sotalol, class 3, in a randomized fashion. And people have long ago recognized AFib is not all or nothing. AFib, the goal of therapy was to make people have fewer or less symptomatic or shorter episodes of AFib. Wiping it out seemed inconceivable. So the endpoint for the early antiarrhythmic trials was not elimination of AFib, but measuring how long it took before a patient had symptomatic AFib, usually with an outpatient monitor to document that. And if you put a line at 50% and your recurrence rate is, actually this is percent without recurrence, as you look at this, you can see clearly you do better with amiodarone. Going out 600 days, half the patients had not had recurrence. But what we would measure is the median time to recurrence, and that's what this red line demonstrates. And clearly, propafenone and Sotalol are about the same. Amiodarone was clearly better. Now, the safety study, on the other hand, included placebo. Because the last study, okay, one's better than the other, but what about no drug? Do these work at all? And safety actually had amiodarone, Sotalol, and placebo. And in this study, after about 800 days, half the patients with amiodarone had recurrence. Sotalol, they went out to about 200, and recurrence with placebo within weeks was very common. More than 50% had a recurrence. So in this way, it was demonstrated that actually antiarrhythmic drugs at least have some effect measured in this way in atrial fibrillation. Now, subsequently, other meta-analyses have been performed, and this one looking at a number of different studies, looking at amiodarone versus rate-controlling drugs, and clearly, if you're on amiodarone, you have about a 3-time better, or odds ratio of improvement of 3 times in terms of maintaining sinus rhythm versus no antiarrhythmic therapy. And the same statement from AHRQ in comparing Sotalol with amiodarone actually did not find a significant difference. My own clinical perspective is that amiodarone is more potent in patients with atrial fibrillation. Now, I mentioned amiodarone has all these side effects. Wouldn't it be nice if we had an agent that was safe amiodarone? We don't. But the hope was that Dronedarone would be this drug. it was designed to be comparable to amiodarone. And amiodarone is called a class 3 drug is an oversimplification. Amiodarone affects all of these various channels, which we'll talk a little bit more about. It's a derivative of amiodarone. It's less lipophilic, and it has been demonstrated in a number of trials to have antiarrhythmic efficacy. I'll show that to you. It has a dose-dependent effect on conversion spontaneously, pharmacologically. And finally, it slows the rate of AFib, which isn't a bad thing in most patients. But does it have antiarrhythmic efficacy? These are the 2 early studies with Dronedarone. And these are the opposite of the Kaplan-Meier type curves that I showed you. This is the cumulative incidence of recurrence. And if you draw that 50% recurrence line again in these 2 studies, this is more European and this was American, you actually find that even though just about everybody's getting recurrence, the amount of time to first recurrence is prolonged by 2.3. And the overall reduction in risk were 22% and 28% respectively. So this is an antiarrhythmic drug. Not super potent, but there was hope that this drug would be the safe alternative, a less toxic alternative to amiodarone. The problem is that there was then a study called Andromeda, which demonstrated increased mortality after Dronedarone. Now, the inclusion criteria are important in this study and for subsequent studies. Specifically, these were patients with new or worsening heart failure. They had been hospitalized with class 3 or class 4 heart failure or had PND within a month. So they were pretty sick with heart failure. EF was all less than 35%. Interesting for this study is AFib was not required, although by history 40% of the patients had AFib. And at enrollment, 25% were in AFib. And Andromeda was terminated early because of mortality concerns. Actually, 8% mortality on Dronedarone versus, again, a sick group, 3.8% on placebo. And this is where I got involved in the Dronedarone story, and I'll share with you kind of, again, as I said, my own personal journey with this drug. I was asked to be the one American in the largest antiarrhythmic trial to date called ATHENA. And ATHENA had the hypothesis that treatment with Dronedarone would prolong time to first cardiovascular hospitalization or death in moderate to high-risk AFib patients. So it's a safety trial. It's an antiarrhythmic drug, and you look at the hypothesis, and it's not about AFib unless AFib is causing some of that cardiovascular hospitalization. So this is a safety trial because efficacy had already been demonstrated. And in retrospect, probably they didn't want any chance of efficacy not being shown again, in retrospect. So the primary outcome was time to first cardiovascular hospitalization or death from any cause, but then secondary outcomes, all-cause mortality, cardiovascular death, and cardiovascular hospitalization. There was a subgroup analysis, here we go, a subgroup analysis later that I actually authored that did show antiarrhythmic efficacy in this study as well. But this was the endpoint for this study. And what you're looking at is cumulative incidence of that cardiovascular death or hospitalization over time with placebo versus Dronedarone. And this hazard ratio was 0.76. There were about 4 or 5 more zeros there. This was overpowered for a tremendously impressive result of this study, showing statistical significance and what looked to be clinical significance to this outcome. So I was thrilled. Here's an antiarrhythmic drug, pretty good, which seemed to actually make people live longer or be hospitalized less commonly with structural heart disease, although not the bad heart failure from that other study I showed you. So, to my surprise, when the drug was taken to the FDA, the indication was, and the approval was for prevention of cardiovascular hospitalization in patients with non-permanent atrial fib or flutter, independent of whether they're in or out of AFib or flutter. So as an electrophysiologist, I found this a bit troubling. But at least with that indication and the knowledge that this was an antiarrhythmic drug, why not try this drug as an early step to see if it worked? It would be a safe alternative to the other antiarrhythmic drugs. Now, the manufacturers of this drug thought this was amazing, and they went on to further investigate whether this drug just ought to be in the water and whether AFib even mattered. And so they started PALIS, a randomized double-blind placebo-controlled parallel group study for assessing the clinical benefit of Dronedarone 400 BID on top of standard therapy in patients with permanent AFib. Permanent AFib. So now you're giving an antiarrhythmic drug for patients who you have no thought that you're going to convert. A couple things happened in my own personal saga. I didn't like this concept, and I declined participation. I'd also been an enthusiastic supporter of the of Dronedarone and the ATHENA study, which I stood by. I was on the steering committee for it. But I actually got beaten up in the press a little bit in an interview, which the article made me either seem corrupt or naive. That this paper that was under full FDA supervision and published in New England Journal, they were worried about the fact that I looked at every case report form, which was kind of the way they posed the question. I also was starting my time as FDA chair of the Circulatory System Device Panel, and for the younger people here, if you ever have a chance to attend an FDA meeting, go. It's really interesting, and if you ever have a chance to serve our federal government in that capacity, I encourage you to do it. It's been one of the most meaningful things that I've had the chance to do, but I wanted to be conflict-free. I was a little bit troubled by where this was going, and I'm now showing you data that I was not a part of. So PALIS. So again, antiarrhythmic drug, pretty good antiarrhythmic drug. Safety trial, really safe, seemed to be really good for just about everything. And then, okay, let's see if it's good for patients with AFib, just for whatever ails you. Well, this was a result, and in New England Journal fashion, this is the scale of 0 to 1. This is blown up. This study, which was looking at the risk for first co-primary outcomes, stroke, myocardial infarction, systemic embolism, or death from cardiovascular causes, this is placebo, this is the drug. This is not a safety trial. This is a trial that demonstrated significant risk in the patients who were enrolled in this study, permanent AFib, and that resulted in a black box warning. So here this drug is flip-flopped. Seemed to be good, had a safety issue, then appeared to be really safe, and now this. And the black box warning is for increased risk of death, stroke, and heart failure in patients with decompensated heart failure or permanent atrial fibrillation. It's contraindicated in patients with symptomatic heart failure with recent decompensation requiring hospitalization or class 4 heart failure. That was the group that was studied, and it doubled the risk of death in those patients. And its contraindications indicated in patients with AFib who will not or cannot be cardioverted into sinus rhythm. So basically, again, saying it one more time in case you didn't get it the first time, double the risk of death in patients with permanent AFib. And why would you give an antiarrhythmic drug to someone who you don't have any hope of changing their rhythm anyway? So I think they got off course, but actually I'm glad this study was done, because it means you got to be really careful with this antiarrhythmic drug. So what do we do with antiarrhythmic drugs? This is the algorithm from 2014. It came up, of course I put my talk together for this and talking about antiarrhythmic drug, and then just within the last week, Heart Rhythm Society, AHA, ACC came out with an update to the guidelines of AFib. I said, oh boy, I got to change my slides. I don't have to change my slides. I spoke to one of the authors. There's no new update on antiarrhythmic drugs for AFib. So this remains the recommendation. I'd just like to remind you, if there's no structural heart disease, you now, since the 2014 guideline, have the option of skipping antiarrhythmic therapy completely and going straight to ablation. And young people with normal hearts, I don't think that's at all unreasonable. On the other hand, if you do try an antiarrhythmic drug, these are alphabetical, not in any other hierarchy. My own recommendation is that I go with flecainide if I'm convinced the heart's structurally normal and there's no ischemic heart disease. In either case, if the first drugs don't work, go to ablation, and if either case is not effective, you can consider amiodarone. Again, off-label, but lots of data for safety and efficacy. If there's structural disease, you base your drugs on coronary disease or heart failure. The negative inotropes you avoid with the heart failure. Catheter ablation is an option. The latest study coming out suggested there may be a mortality benefit in heart failure. That's a subgroup analysis that I don't know is going to. I wouldn't follow that necessarily. And then amiodarone or catheter ablation are the common denominator as options in the end. So AFib is complicated. Now I recognize I have oversimplified the concept of AFib and the concept of therapy. But I would make note that you have these autonomic vagal plexi here that play a role. You do probably have reentrant rhythms, and possibly chopping up this or prolonging the wavelength will change the frequency of AFib. AFib early on was recognized as emanating from firing locations, typically in the pulmonary veins, but also these other green dots show other areas where you can get firing foci that initiate and may perpetuate AFib. And this is a combination of all those basically saying it's a mess. We ablate, we think we know what we're doing, and we're having really amazing results from AFib ablation. This is just an example. Looking at the back of the heart, left and right superior and left and right inferior veins. This is the left atrium. There's the back of the head of the individual with this left atrium, and these dots are all radiofrequency lesions. And basically, by putting in these lesions, we're probably doing a number of things. We're chopping up the atrium. We're having an effect on the isolating the pulmonary vein and other firing foci, and we're probably knocking off some vagal input as well. I thought I'd bring you back to my time in 1982 to 83, where we chopped up the dog atrium a little bit. This, to orient you, this is the heart, this is SVC, IVC, this is the right atrium. And my project as a medical student was to modify an old mechanism for inducing atrial arrhythmias, which was a single lesion, and what we did is add another cut. So this was an open chest cut and sew procedure on the dog heart, and then we put electrodes on that would map this. Our theory was we wanted a wavelength of an atrial tachycardia that would have what's called an excitable gap, so we wanted a larger barrier to go around. And our concept was the reentry would go around this gap, kind of on top of, in the posterior wall of the atria. Well, it was actually really exciting for me at the time to get to do these experiments and study these animals and induce atrial arrhythmias. And indeed, in 100% of those cases, the minute you did this, you were able to induce acutely and chronically. We had them chronically instrumented to induce, just by doing burst pacing, you got a rhythm that looked like atrial flutter. And what was interesting is, you can't really see it here, but we decided we wanted to map it. And for the electrophysiologists who do cardo maps, welcome to the 80s. And this was a handmade map with, I think, about 64 electrodes. And we'd get a couple beats and spend 2 weeks analyzing the electrograms for just a few beats. And we had these egg-shaped electrodes. We used a Langendorf prep heart, and the puppies still haunt me, but actually there was one dog perfusing the other, and there was 100% mortality for our puppies. So, but at the time it was really exciting, and we were learning something important, I think. And when we mapped this rhythm, thinking it was going to go around the scar, it didn't go around the scar. Anybody have a guess where it went around? It went around the tricuspid annulus. So, and those of you here know a flutter occurs around the tricuspid annulus. We weren't smart enough to think humans did that, but we thought it was really interesting that the dog had flutter around its tricuspid annulus. And just to orient you, this the coronary sinus ostium, this is a little bit of the pectinate muscle, and this is these beautiful fibers that actually travel circumferentially around the tricuspid annulus and are a perfect racetrack for the reentrant rhythm of atrial flutter, in this case in dogs. And I had the opportunity, it's a little bit dark, to generate the first perfusion study, and actually this is the tricuspid annulus removed from the dog, put in a superfused tissue bath, bubbling Tyrode solution out of it. It looked like a volcano. It's been compared to several other things over the years, but we induced atrial flutter in this, and it was a eureka moment for me, being there as a medical student, seeing this. But the other interesting thing is, as a proof of concept, when we took a scalpel and cut the rhythm, of course, it cut the tricuspid annulus, of course, it terminated the arrhythmia. And then coming full circle, over 30 years later, it was really an honor to serve as the writing committee chair for the SVT guidelines, where we actually gave recommendations for flutter. We weren't smart enough, but subsequently in humans it was documented that atrial flutter, typical flutter, comes encircles the right atrial ring and the tricuspid annulus, and these are the guidelines for atrial flutter. And in point of fact, catheter ablation for atrial flutter is now first-line therapy. It just makes sense. Just like cutting that tissue, if you eliminate the substrate, you do not have that rhythm anymore. So unlike a fib, I don't give a shot to antiarrhythmic therapy for flutter. I recommend directly going to an ablation. And for those who aren't people who do ablation, this is a much simpler ablation. You're only on the right side of the heart. You're dragging from the right ventricle across the annulus into the IVC to make a lesion that eliminates the flutter. So what are our other ion channel options? Let's go back to the drugs. And Dan Roden and I, when we put together this paper, we tried to summarize everything in terms of channels and renin-angiotensin and all the different substrate changes that were going on. But the goal really is to reduce the risk of torsade. Wouldn't it be great if you could affect the atrium and not the ventricle? So you eliminate a fib like that patient I showed you, but you don't induce torsade. What you need to do that is look for other areas where you might have an effect, and to look at channels that could be targets. So back to our action potentials. You should know that the atrium is different from the ventricle. They have different ion channels. They have different morphologies to their action potentials. And if you can find the differences and potentially poison the selective channels, you might have a positive effect. So the transient inward current is better represented in the atrium and probably has greater effect in the atrium than in the ventricle, where you don't have that immediate downstroke. ITO could potentially be a target. Side effects in the atrium, you might have a greater effect in the atrium than the ventricle because there's greater influence of ITO. The ITO is even more prominent in the remodeled atrium, so wouldn't it be great if we had antiarrhythmic drugs which specifically went to remodeled atrium? And finally, it's still present in the ventricle, so you have to worry about some risk of proarrhythmia. What else do we have? We have the ultra-rapid current, which you can see is atrial and not ventricular. This may represent an atrial-specific target, but there are possible limitations to this as well. What else do we have available? The potassium acetylcholine dependent potassium channel. This is related to vagal influence, but it's also constitutively active in the atrium. There's, even in the absence of vagal tone, this is active, and it's not evident in the ventricle. So again, might this be a target? Parenthetically, we're already poisoning IK-ACH because there is some effect already in the antiarrhythmic drugs that we've been talking about, flecainide, quinidine, and maybe it's contributing to those effects. So what are the new agents we have? Well, as I said, it's kind of disappointing. For someone who's been following this all along, there aren't that many new agents. Going back to these various locations, sodium, IKUR, and IKACH, vernicalin, that's not making any progress, although it is approved for conversion in Europe. It's not in the United States. Ranolazine you've heard of, and I'll mention a little bit more about that. And other agents trying to aim at IKUR so far have been unsuccessful. And you haven't heard about them because early stage investigation is disappointing. So the one area that we've had any publications in the last few years on is ranolazine. And just to remind you, ranolazine is FDA approved as an anti-anginal. It blocks several ion channels, predominantly the late sodium channel. It also has an effect on the sodium-calcium exchanger, as well as other channels. At the atrial level, ranolazine can cause use-dependent inhibition of peak late sodium and IKR currents. There can be a modest increase in the mean QT interval with ranolazine, so you need to be careful about that. In two studies of ischemia, Merlin Timmy 36 and Raffello, there was some suggestion that there were less arrhythmias with ranolazine. So it has been studied in AFib, most recently combining ranolazine with Dronedarone. I'm not putting this forward as something you should do. I want you to be aware that people are still looking and trying, and recently I was contacted by the people who market Dronedarone, and they're hoping to revive interest, and I'm told them I'm doing something else these days. But in Harmony, you should be aware there's some suggestions that there might be some target here. The hypothesis is combining agents with multiple anti-AFib mechanisms at reduced individual dosing might produce synergistic efficacy and better tolerance and safety. So in this case, 134 patients with AFib and a pacemaker were studied looking at AFib burden. So now not looking at time to recurrence, but how much they're AFib they're in AFib based on quantified recording from the pacemaker. And they used mid-range ranolazine, 750 BID, combined with two reduced Dronedarone doses. And it was randomized, double-blind, to actually 5 different groups. And here are the results. This is looking at percent change from baseline and placebo and low dose of Dronedarone, not much effect. Low dose of ranolazine, a little bit of effect, but in terms of reduction of AFib burden, at these 2 doses, 750 of ranolazine, 150 of Dronedarone, or 750 and 225, you see a dose-related effect. So some signal there. They looked at the ventricular rate, and the overall rate was reduced several beats per minute, 12, 13 beats per minute. So some antiarrhythmic efficacy. So what can we take from this study? Combination therapy was tolerated. Neither placebo or drug alone had a significant effect, but combined there seemed to be a statistically significant and maybe clinically important result. And there was some effect on heart rate. So what are the alternative strategies? People are still looking And monoclonal antibodies are now being examined to potentially reduce C-reactive protein and other inflammatory biomarkers that could be related. Colchicine, a potent anti-inflammatory, reduces cytokine production, is being looked at as maybe an antiarrhythmic drug or a reduction of AFib. Minoxidine, currently a centrally active sympathoinhibitory agent, modulates the sympathetic limb of the autonomic nervous system. That's being looked at. And there's investigation into pharmacogenetics that might determine so we could better give individualized therapy for patients rather than hit or miss, which is what I've shown you, to actually identify who's going to respond before we give them the poison, which is also the potential treatment for their AFib. So in closing, antiarrhythmic drug therapy clearly reduces AFib and reduces symptoms. All antiarrhythmic drugs have toxicities that we need to consider, and they should inform our drug choice depending on the patient. The choice of therapy must be considered in the context of the clinical characteristics. An 80-year-old patient who has newly identified AFib, or someone who just found it on their Apple Watch or whatever, and they have no symptoms, they need antiarrhythmic therapy like they need a hole in the head, as compared to thinning their blood as appropriate and rate control if needed. And finally, new targets and strategies. I'm still hopeful that we'll find some way that is not toxic to the ventricle and reduces AFib. So in terms of my own personal journey, one of the greatest gifts in my life was having the opportunity to serve as chief of cardiology here. And you have welcomed me warmly. It's amazing looking out at friends who y'all haven't aged a bit, and I know I haven't either. And seeing the next generation coming up through, meeting the fellows. It's a wonderful program, and I'm tremendously fortunate to have spent time here. I want to acknowledge Werner Sampson and his wife Joni, who hosted us for dinner last night. It was an evening rich with memories of being at their home 15 years ago. And finally, this is, I showed looking west. This is actually looking east. This is University of Vermont, and those are the Green Mountains. And I do thank you all for the opportunity to serve as the Sampson visiting professor. Thank you.
Before we embark on questions, that picture gets an opportunity for the 2019 re-up, so faculty and fellows can join us over at the usual stairs by the other auditorium for photos afterwards. That'd be great. And then we'll open it up to questions from anybody.
Yeah, Catherine.
Always a question. So you mentioned it's all about symptoms, but why do some patients with atrial fibrillation have so many symptoms and other people with the same or bigger burden can care less? What drives symptoms?
I would love to know. I have no idea. I think older people generally don't notice it as much as younger people, and more sedentary people probably don't notice it as much as more active people. Those who are on, I don't know about y'all, but these heart rate monitors, I was exercising this morning and it was telling me my heart rate, and someone who's always been 120, 130 or something, they're going 180, 140, and they recognize that, and they come in and they say, is this important? And my people get very excited about it, but my question to the patient is, how do you feel? How does this bother you? Oh, it really bothers me. Well, what bothers you? I take my pulse and it's not regular. Well, there's a real good answer to that. And then stop taking your pulse. But then once they learn, they're really troubled that something's off. And that's where you're able to give them data that demonstrate rate versus rhythm control. There's no significant difference in the studies that were in all comers and in heart failure. So I don't know, Catherine. It's really an interesting question. What I tell patients is you're one of the lucky ones, because now we can talk about what we need to do other than keeping you from feeling really miserable with your AFib. Yeah, David.
Yeah, Rick, that was a wonderful talk. So how about this new data on ablation and heart failure?
That is that Cabana. That wasn't the endpoint for Cabana. They tortured the data some, but I think there may be a signal there. I don't know how we're going to figure out how strong that signal is, because Cabana took forever, and people don't want to be randomized. I wouldn't necessarily jump in yet, but it's something we need to look at and something we need to consider. And others may be more convinced. I see Dr. Poole, who can correct me. Okay, and Greg.
Well, I was going to question about something else, which I will ask you, but I guess just in terms of that whole heart failure thing, the Castle AF trial in heart failure demonstrated decreased mortality of about 350 patients or something. What would be interesting is that in Cabana, some analyses are looked at is to look at the group of patients in Cabana that also had heart failure. That paper unfortunately went out yet.
Didn't they present that in abstract? Wasn't that one of the highlights of the abstract?
So was it?
If I'm remembering it. You're in the game more than I.
It wasn't focused on in the Cabana presentation last May, but it is in the forest plot that shows that patients, there were 337 or so patients that had heart failure in Cabana. So on the forest plot, they looked like they had.
And it looked like it was trending that way.
But even by ITT, but it was a big hoopla in terms of the analysis of Cabana. But hopefully that paper will be coming out in a month and people can read it and make their own decisions and judgments. But the question I really want to ask you, first of all, wonderful review. It's so great to be reminded that we have a long journey with antiarrhythmic drugs, and while we all think Fibrillation was fantastic, we need drugs and we use them all the time. It'd be great to have new antiarrhythmic drugs come out. But you touched on a concept that I want to get your opinion on, which is this idea that patients don't have to have all atrial fibrillation suppressed to feel better. And in the ablation history of all of the ablation trials up until the recent ones, the goal, the primary outcome of most of those trials who had a rhythm outcome was getting rid of all atrial fibrillation off of the antiarrhythmic drug. So I wanted to get your opinion on that.
My perspective is pretty simplistic for taking care of patients. There are two reasons I intervene: to have patients live longer or better. And there's no suggestion, maybe we can argue about in subgroups, for them living longer from these interventions. And some worry that they live less long with the wrong antiarrhythmic drug in certain patients. So the issue is, how do they feel? So I don't care if they're having AFib. If they're going to be, their blood's going to be thinned anyway, and that's the thing that up front I tell patients, and patients are very often disappointed. But if they reach guideline antithrombotic therapy, even if we think they're cured because for whatever reason they've had an ablation and we don't see any more AFib, I thin their blood. So the issue is, do they feel better? And again, with ablation, it's not all or none, and certainly with antiarrhythmic drug therapy, it's not all or none. But back before we had ablation, if I brought someone to get cardioverted only once every 6 months as opposed to once every few weeks, that was a win. So we'd love to have it wiped out, but it just so far has not been a realistic outcome.
Greg.
Your early work on AFib, begetting AFib, is really fascinating.
It's not my work.
Your field's early work. And so I'm curious, will we ever be able to detect risk of AFib and prevent it?
Yeah. Well, the issue is, can we detect risk of AFib? There certainly are risk factors for AFib, and there are genetic risk factors, and there are certainly familial AFib. But with 1 in 20 patients over 65 and close to 1 in 10 over 80 or 85 having AFib, it's the common denominator for many people just living long enough. So the issue of upstream therapy, I was involved in a trial of fish oil. Dari Masafarian, everybody remember Dari? Dari's a dean at Tufts, I think in part to make amends for the fact that he changed his mind after I recruited him here, he put me on the steering committee for this trial, and there was a lot of hope, and that didn't show anything. So maybe some of this new upstream stuff will work, but I'm not very optimistic. What's the best thing to do? Well, for everybody I say diet and exercise. keep from becoming obese. At the same time, there are data that are significant that suggest that the heavy-duty exercisers, they probably get more AFib than not. So maybe not too much exercise. Yeah.
Great summary, and I want to also continue from what Greg just asked. You talked about electrical remodeling pretty much, but do any of the drugs or any potential drugs or potentials have an effect on the structural remodeling side that often accompanies AFib and this AF begets AF concept?
I'm not aware of that other than the concept that anti-inflammatory treatment may reduce inflammation and fibrosis, but I'm not aware of it. You might be.
I want to say thank you to Dr. Page.
Thank you very much.